plática. Muchas gracias, Ike.
Gracias, Mauricio. Buenas tardes, todos, amigas and amigos. That's all my Spanish I can say today. So I want to welcome you all and thank you, Mauricio, for your very kind hospitality. Always a guy who's on the edge and a great friend of ours. So thank you, Mauricio. And it's great to be here with a great group of panelists here across the globe here in Spanish. And so I'm going to be presenting something which is, I hope, useful for you. And I have 10 pearls to speak about surgical management in angle closure. I also want to thank the special arrangements that the group has made to translate my bad English into hopefully better Spanish. And so I hope that'll be helpful for you as well. And this is my city, and these are my disclosures here as well. So the first thing I want to, again, emphasize, I think we know this already, and I won't spend lots of time on this, but crystalline lens removal is a very effective strategy for angle closure. In fact, I would go to the point to say that I avoid any filtering surgery in a patient presenting with angle closure. It's very rare to start with filtering surgery in my practice. We know, of course, from the imaging, the significant volume the lens takes in causing angle closure. And we have good studies. For example, the EAGLE study looking at phaco versus iridectomy in patients with angle closure or glaucoma. And we see the benefit in terms of phaco here. We also have examples of patients who have angle closure glaucoma, either controlled or uncontrolled, and we see the benefit here again of phaco versus phacotrabeculectomy. So I think both of these really, I think, emphasize the value of doing lensectomy. But lensectomy in these cases are not without its own risks. It can be effective in terms of lens removal and creating space, but the risks are numerous in terms of both preoperatively, intraoperatively, and postoperatively. I won't go through all of these, but there are very serious complications that may occur that I'll focus on here today. We can define eyes based on axial length in terms of the size. Usually when we get down to below 21 millimeters, it starts to raise concern for the risk of surgery in these eyes. And of course, less than 20 millimeters or nanophthalmic eyes are particularly a concern. This study nicely showed that the smaller the eye gets, the higher the risk is for complications. And you can see once you get down less than 19 millimeters, there's a 20 times increased risk of complications, which is something we need to consider. And these complications include effusions and malignant glaucoma, which we'll deal with. One of the keys in dealing with angle closure in small eyes is the creation and maintenance of anterior chamber space. We have to deal with shallow ACs and corneal endothelial problems, and we have to prevent shallowing that can cause intraoperative malignant glaucoma. We use mannitol, typically given about 30 to 45 minutes before surgery, at a dose of 1 gram per kilogram. I think this is effective at dehydrating vitreous. The right viscoelastic can be helpful, including superviscous agents like Helon 5 at making space. And there's a question, and I'll raise this later on, about doing pars plana taps. Again, we use dispersives to protect the cornea, and we use more cohesive agents, and I hate to use trade names here, but these are unique compounds that are effective in these difficult cases. Positive pressure is a problem in these small eyes, and they can be considered from numerous sources. It's important to address these and identify these early on to solve and prevent these from occurring. One of the important points is to ensure the chamber is always maintained. And in this video, you can see when we remove the instruments from the eye, like the irrigation handpiece, we always keep the chamber formed. Any chamber shallowing can risk and potentially cause swelling in the choroid or an effusion. Should you do a pars plana vitrectomy or a tap? This is an example where we have really inability to create space in this very small eye. How we will do the surgery and access the cataract. Of course, it's very tempting, and we have now good tools for antersegment surgeons to make pars plana taps using trocars, which I think reduce the risk of vitreous incarceration and add more control for the antersegment surgeon. We also have high-speed cutters that are useful in vitrectomy. The problem is, however, where does the pars plana end? And normally in regular eyes, the ora serrata is around 6 millimeters from the limbus. We can safely enter 3.5, 4 millimeters back from the limbus and we'll be okay. But in these small eyes, the ora and the retinal insertion may be up to 2.5 millimeters from the limbus. And this means that if we enter too posteriorly, we can enter through the retina. We have to be very mindful of this. And if we do go through the pars, we need to make sure that we are very mindful and perhaps go more anteriorly. However, we may hit the lens. UBM may be helpful. This is an example of a case where you can see that the surgeons made these incisions and iris is prolapsing out. There's very little space you can see here that's present, and the initiation of the rhexis is difficult because there's no room. So here, in this case, a UBM was done preoperatively, and we know that the pars plana is at least 4 to 5 millimeters back from the limbus. What we do in these situations here, we're going to enter, in this case here, you can see we're entering about 2.5 millimeters from the limbus and entering very steep away from the lens. This does risk hitting the lens. These eyes have a big lens often, but by pointing posteriorly and entering anteriorly, this can help avoid that. And a small limited vitrectomy, only a small amount, while reforming the anterior chamber, now resolves the problem and adds enough space for us to do the lens removal. Now, what about uveal effusions and the role of sclerostomy? We know with nanophthalmic eyes, there's a variety of complications associated with these very small eyes because of the thick choroid and the thick sclera. Effusion syndromes, malignant glaucoma, and serous retinal detachments are all risks. Here's an example of a very obvious choroidal detachment in a nanophthalmic eye preoperatively. However, you see in these cases here, I'll point it out, these are small annular anterior infusions you can see present here, which may not be readily visualized by examining the fundus. This is why I think it's imperative to do B-scan and ideally even ultrasound biomicroscopy so we can address these. For example, some of these eyes have a pre-existing preoperatively effusion. It's important to do a cut down 4 to 5 millimeters back from the limbus down to full thickness sclera and release the effusion present. Typically, I make 2 sclerotomies, temporal and nasal, to release this effusion, to deepen the chamber and allow us to do the surgery safely. Imaging can be helpful. What about prophylactic sclerotomies? Patients don't have an effusion, but should we do it prophylactically? This study implied that the use of a sclerotomy may be helpful to prevent postoperative uveal effusions. Keep in mind, if we do a vitrectomy, this can actually make effusions worse. Another reason we need to be mindful and careful and not just proceed into vitrectomy if we don't need to. What about malignant glaucoma? Malignant glaucoma can occur because of choroidal expansion in these very small eyes. The choroid is very thick, and you can see the thickness of the sclera as well. And the constellation of findings with shallowing, choroidal expansion, vitreous pushing forward, and a small eye can result in a very shallow chamber. In these cases, the definitive treatment is to create a unicameral eye, allowing aqueous to drain from the anterior segment to the posterior segment and vice versa. This is what we call an irido-zonulo-hyaloidal vitrectomy, and can even be done postoperatively for an eye that's shallow after cataract surgery, as an example. This is an example of a patient who has a very small eye. You can see the shallowing of the chamber and the very short axial length. How do we do calculations in these patients? Well, we know, of course, that typically a small eye means a shallow chamber, but not necessarily for a very small eye. So using new generation formulas to take into account anterior chamber depth, white to white, as well as axial length, can provide a more accurate calculation, although all calculations are difficult in these small eyes. Here's an example where we have piggyback lenses. It's not a good idea. On the other hand, using a very high power lens like these options can be useful. The Human Optics Aspira can go to 60 diopters in its power. So keep this in mind as an option. When we have synechia present, it's helpful to do goniosynechiolysis. And this is an example just to show a video showing a mirror where you can see we have the angle visualized with a gonia mirror, and we can use a pair of forceps here to release the synechia to allow the angle to open. So it's important and helpful to take a gonia mirror and allow us to use this to be able to visualize the angle and open the angle. So to summarize, these are my summary slides here. It's important to be aware of important complications like effusion syndrome and malignant glaucoma. Lens removal is very effective when we typically avoid filtering surgery as much as we can. Space creation and maintenance is important, as we mentioned earlier, and for eyes that are small, I typically avoid a pars plana incision for concerns I mentioned because of potentially going through the retina. Instead, mannitol is very helpful. Less than 20 millimeters, I always do iridozonular hyalodectomy to create a unicameral eye, using the vitrectomy to go from the anterior chamber into the vitreous through the peripheral iris. And for eyes that are less than 18 millimeters, I think a prophylactic sclerectomy is useful to prevent postoperative uveal effusions. So those are some advice for dealing with small eyes in these difficult glaucomatous cases. Gracias. Thank you.
Muchas gracias, doctor Ike Ahmed, por su brillante participación. Vamos a dar paso a la plática del doctor Félix Gil Carrasco. El doctor Félix Gil Carrasco